You are listening to Hillary Topper on Air. And now, here's your host, Hillary Topper.
Hi, everyone, and welcome back to the show. If you've ever had a nagging injury slow you down or wondered how to stay active after a major procedure, this episode is for you. Today, we're talking to someone whose work helps transform lives both in and out of the operating room. I'm so excited to introduce my guest, Dr. Sabrina Strickland. Dr. Strickland is an orthopedic sports surgeon at the Hospital for Special Surgery, widely recognized for her expertise in knee and shoulder injuries. Her mission? To get her patients back to what they love to do, whether that's training for an Ironman, taking a casual jog, or simply walking around New York City. Through her compassionate care and cutting-edge technologies, she's helped countless individuals overcome setbacks and return to active lifestyles, including myself. She's been my surgeon for the last 10 plus years. Dr. Strickland, welcome to the show. Okay, so I would love to hear why you decided to focus on knees and shoulders for your practice. And can you also give us a little background about yourself, Dr. Strickland?
Sure. So when you're in medical school, you rotate through all sorts of things. You rotate through neurology, you rotate through internal medicine, you rotate through general surgery, and then you can do sort of electives. And so for surgical electives, I did orthopedic surgery and I did ophthalmology. And I didn't like anything about the eye, but I really liked orthopedic surgery, and partly because you could be really helpful. I mean, a lot of orthopedic surgery is bigger surgery. I mean, people think about breaking bones and using saws and drills, but also as a med student, you're holding retractors and you're holding an extremity. And I think it was just, you're more engaged and it was more interesting. And also, contrary to popular belief, like, it's not like we just treat athletes. Like, a lot of my patients are athletes, and maybe some of them want to play or are playing college football, but other people just want to stay on their Peloton, or they want to be able to go hiking on the weekends. And that really appealed to me about orthopedics, because it's a huge range of patients. In my field, I could take care of a 12-year-old and I could take care of a 72-year-old in the same day. And in some ways their goals are different, but a lot of their goals are the same, as far as just trying to be as active as possible. And then your question about knees and shoulders. So within sports, within orthopedics, there's sports, which is sort of knees and shoulders. Some people do some elbow, some hip. But sort of the most interesting to me was knees and shoulders, but I really do about 95% knee. And that's as I've got more senior and I've been doing this longer. This is now, I think I just am finishing my 23rd year. I've become a lot more focused on knee preservation.
So knee replacements are becoming so incredibly common. And I know many of our listeners are wondering about the limitations after a full knee replacement. Can someone with a knee replacement continue to run, or do they need to find alternative ways to stay active?
So a knee replacement is a resurfacing. You essentially take all the surfaces of the bone off and you replace it with metal. So you do that on the end of the thigh bone, and you put the same piece of metal on the top of the shin bone with a piece of plastic in between. And it can be pretty clunky. Like, people hear the clicking, but it also tends to not feel as natural. So I discourage patients from running. And of course, I want patients to be able to run across the street so you don't get run over by a bus, but it generally doesn't feel that great to run. So for the vast majority of patients after a joint replacement, we tell them to bike, swim, walk, hike, maybe play doubles tennis. But generally, I don't think running is the best sport after a knee replacement. I think most people don't like it after a knee replacement.
So a knee replacement is pretty major surgery. Are there alternatives to a knee replacement, or does everybody need a knee replacement that has osteoarthritis?
So no, there's a lot of alternatives. And so there's certain operations that we've been doing for 40 or 50 years. So that's osteotomy, where you cut the bone and you try to realign it. So if you're really bow-legged and you have arthritis on the inside part of the knee, you can cut the bone and make your knee more knock-kneed, or vice versa. If your kneecap arthritis, if it's all kneecap arthritis, it's all in the front of the knee, we can just cut the front of the bone and realign it. So there are things that we can do that we've been doing for many years to try to reduce symptoms and reduce the stress on the bone for arthritis. There's a lot of new technology that has been designed to try to delay at the very least and hopefully avoid a knee replacement. And so that I think is the most interesting part of my job.
Let's talk about shoulders. I know you said it's only about 5% of the business, but so shoulder injuries are pretty common among swimmers. If someone has a shoulder injury, like some type of a tear or something like that, can they still swim? And what modifications or precautions do they need to take?
So labral tears are super common in swimmers, and the vast majority of swimmers can keep swimming, and it's pretty rare that they need surgery. That's kind of more a wear and tear. I mean, obviously swimming is involving a huge arc of motion in the shoulder, and the rim of the socket of the shoulder has a structure called the labrum. It's very similar to the meniscus in the knee, and a lot of times that can tear. And if you do appropriate strengthening, you really strengthen the muscles around your shoulder, you really strengthen the rotator cuff, many swimmers can get back to swimming without surgery. A rotator cuff tear is a little bit different. Rotator cuff tears tend to be in patients who are over 40. And if it's actually fully torn, the only way to fix that is with surgery, and it's actually taking that tendon and bringing it back to bone. That is a surgery we do very commonly. It's a bear of a recovery, meaning you're stuck in a sling for 4 to 6 weeks. You're typically not back to full swimming for at least 5 to 6 months. But I have patients who've got back to distance swimming up to the age of 80 after a rotator cuff repair. So it can be very successful. It's just not a walk in the park.
Ouch. So let's talk a little bit about meniscus tears, because that seems like a very common concern, especially for runners or active individuals. Can you break down what a meniscus tear is and how it typically occurs?
So the meniscus is the shock absorber. The thigh bone, the ending of the thigh bone is round and the top of the shin bone is flat. And so you have these two C-shaped structures in there, and they're basically almost like a piece of rubber, two pieces of rubber that absorb and distribute shock. But the problem with them is they don't have a very good blood supply. So if you cut your skin, it bleeds, and then that skin heals back side to side, and it essentially, you might have a little scar, but it looks as good as new. When you tear the meniscus, because there aren't any blood vessels in 3/4 of the meniscus, if you tear it, it doesn't have any way to heal in most cases. And so in some patients, you'll get a little tear, and then over time, it'll just become asymptomatic, and the tear won't go away, but the symptoms can go away. And those are the kind of tears you want to ignore. So if you have a meniscal tear and you happen to know that it's indeed a meniscal tear because you had an MRI, if you're feeling better and better, there's really no reason to have surgery. However, a lot of the tears are not like that. And so a lot of the tears are a flap, and the piece can get stuck, and it can make your knee feel unstable, and it can cause swelling. And those tears are the ones that we tend to treat, either by snipping a little bit of the tear away or the loose fragment, and in some cases, sewing it back together.
Now let's switch gears again and talk a little bit about ACL tears. What's the difference between a meniscus tear and an ACL tear, and how is an ACL injury different, and what's the recovery like for both meniscus and ACL?
So the meniscus is typically easy if it's just a little piece, if you just snip out a little piece, meaning you maybe go home on crutches, but usually off the crutches in a couple of days. You're immediately bending your knee. There's no brace. Most people feel pretty good almost immediately. An ACL is a ligament reconstruction. So the reason to have ACL surgery is for stability. ACL surgery is not for pain. It's just to get back to sports typically that involve cutting, soccer, tennis, more aggressive skiing. And so those are also the sports that are you're most likely to tear the ACL. So you watch the World Cup, you see a bunch of statistics on ACL tears because they're so common in a sport like soccer. But the recovery is much longer because when we do a reconstruction, we're taking a tendon and we're putting it in place of the ACL, and then the human body has to heal that and remodel that tissue and turn it into a ligament, and that takes 9, 10, 11 months. So that's a long recovery. Patients are typically back to doing a sport like running after 4 months, but it takes a long time before they can get back to a cutting sport.
Wow. So when you are doing sports as a youth, or maybe even a D1 athlete, and you have an ACL injury or you have a meniscus, does this all kind of lead to having to have a knee replacement or a partial knee replacement?
But not always. So ACL tears, the statistics are pretty dismal, meaning about 50% of patients who tear their ACL go on to have arthritis. Unfortunately, I see a lot of patients who are in their 30s who already have arthritis who had an ACL injury and surgery 10, 15 years ago. But not everybody, 50%. I mean, the 50% of them end up doing just fine. And part of that is what other tissues were injured at the same time. So if they tore their ACL and their meniscus, that patient is generally going to do worse than if it was just an isolated ACL. And we keep thinking we're doing a better job with surgery, meaning we're making them more anatomic or we're less invasive. Patients used to get put in a cast for months after an ACL. Now we get them moving immediately, but we're still continuing to see fairly high rates of arthritis. And it takes us 5 or 10 years to know if we're doing things better or not.
Now, let's talk about a lot of people there's so many misconceptions about knee replacements versus partial knee replacement. Why would someone get a partial knee replacement as opposed to a full knee replacement? And what's the recovery like for both?
I actually have that conversation. I had it a couple times this morning, seeing patients. And, the analogy I give is if somebody said, would you like a new car or new brakes, same price, you'd say, I'll take the new car. There's no question. I want a new car. But a knee replacement isn't like that. A knee replacement is a bigger surgery. There's more risks as far as bleeding and blood clot and stiffness. And it's a lot more pain, and it's a much longer recovery. So if only one part of your knee is worn out, there's no reason to really replace the entire knee. And I hear over and over again, and I heard it today, well, if I might eventually need a total, should I just have the total now? And the statistics are that most people have a partial will never need a total. So you typically with a partial, you go home the same day, you're immediately walking with both surgeries, but you may be walking with the walker for the first couple of weeks after a total knee replacement, as opposed to with a partial, you'll most likely be walking with the cane after a week or two. Most patients, when I see them at 6 weeks after a partial, have pretty much their full range of motion and are back to doing day-to-day activities. I would say skiers are typically back skiing after 3 months. After a total, that would be more like 6 months. It's more than twice as bad. And it doesn't feel as natural. So again, if you can get away with the partial, I would certainly encourage going that route. But there's plenty of patients who have arthritis in more than one part of their knee, so partial isn't even an option.
Yeah, I keep hearing people having situations where they're going for a full knee replacement and then it goes bad. They have the full knee replacement. something happens. Sometimes they just never recover from that. I mean, is that a common thing, or is it once you have the knee replacement, for the most part, you're fine?
So the statistics are about 15 to 20% of patients don't like their knee replacement, that they're not satisfied. So that's 1 out of 6 or 1 out of 5. I mean, that is pretty
huge.
high, and that's what you're hearing. And why didn't they like it? So if you look, some people just had high expectations. They thought they were going to run, that they were going to be back how their knee was when they were 16. So that's not going to be the case. So of course, those patients will be dissatisfied. A very small percentage of patients, like 1 or 2%, have a complication, meaning they get a blood clot, they get an infection, they get significant stiffness, and that's essentially unavoidable. We can do everything under the sun to try to prevent those things, but sometimes that happens. But then some people aren't happy because they can't kneel. 30% of patients after a knee replacement just don't feel right kneeling, so they can't kneel. I happen to have a pretty demanding population, meaning my patients want to play tennis, they want to ski, they want to be really athletic. And so, I think it's all about expectations, and it's about moving your knee from day one in physical therapy, and really part of it is under your control and part of it is just your body. I had one patient 6 months ago who told me it took 2 years till he liked his knee. He said at a year he would have given it a 2 out of 10, and now he was seeing me for his other knee. But he said it took him 2 years, and at 5 years he said it was a 10 out of 10. He loved it, but it really took a long time till he appreciated it. And it was interesting because you typically don't see people at 5 years unless there's a problem. He was just in for his other knee, so.
Yeah, I mean, I think that there is this unrealistic expectation when you do have any type of knee surgery that it's going to, you'll be fine. But it does take a long time. I think it takes longer than, sometimes it takes longer than the patient wants. So let's talk a little bit about cartilage damage, because that seems like it's also a growing issue, especially as people push their bodies harder and longer. Are there any advanced therapies or treatment options emerging to address this without major surgery?
So, I mean, stem cells is been a hot topic for more than 10 years. I think I did my first, it was a stem cell trial 10 years ago here at HSS, but it was basically taking placental tissue and processing it. And there weren't actually very many cells in this injection, but there had been some data that it actually helped patients feel better. And so in that first trial, you didn't know what you were getting. You didn't know if you were getting gel or you were getting saline or if you're getting stem cell. And what that study showed is 70% of patients felt better at a year. But that's just feeling better. And your question is there anything that's really stopping cartilage damage? So far on the market, there's nothing that's been proven to stop cartilage damage. It doesn't mean that these products may not slow it down, but it's very hard to prove. It takes a long time. And what we really want is an injection that we can do the minute we're sensing that, or we're getting some data that you're starting to break down your cartilage. We want to do that injection right the day after you tear your ACL, or the day after a car accident, or the day after any type of trauma, or if we know you have a genetic predisposition, to prevent that cartilage damage. Because ultimately, once you have the cartilage damage, yes, we have some newer techniques to fix it, but then it's what you said, it's a surgery, it's a major intervention. It involves atrophy, it involves stiffness, and it involves a lot of recovery.
So just, before we wrap this up, I want to ask you about any innovations or breakthroughs in knee or shoulder surgeries that particularly excite you.
So in that effort to do less invasive surgery, or surgery that causes less downtime for patients. So we have several new things. So we have something called CartiHeal, which is coral from the sea. It was approved by the FDA about 2.5 years ago, and it's for smaller or isolated cartilage defects. And our data so far looks like it works in about 85% of patients.
Wow.
And so is this going to buy that? And it's the first product that was approved for patients who already have some arthritis. generally insurance will deny everything once you have some arthritis. They say just do the total knee. And why are they saying that? Because once you have a total knee, there's no more surgery to do. Even if you're not happy, the insurance company is kind of off the hook. So CartiHeal is new, very interesting. You know, we're still figuring out who are the best candidates, because to get through the FDA, you have to prove that it's effective and it's safe in patients, but you still don't have the perfect algorithm for who to use it for. Then, as you're familiar with Misha, it's an implantable shock absorber. It's now been approved by the FDA for 2 years. So my patient has had it the longest. In August will be 2 years. Again, I think that works in about 85, maybe even 90% of patients. I saw a patient today, I think, who needs another one on her other knee. She loves the one at this point enough that in her other knee, I think, is starting to have the same issue, I think, because I haven't got the MRI yet. But that's very interesting because it's not in the knee. It's a shock absorber that's implanted outside of the knee, but underneath the skin. So it doesn't have any restrictions, meaning if you can stand it, you can do it. We're not worried about something wearing out because it's not in the knee joint. It's not creating little particles of plastic like a knee replacement if you pound on it too hard. So I think that's very interesting, and it's something that we just don't have anything else like it. An FDA trial that we started last fall is Hylex. It's a synthetic cartilage. So it's like doing a cartilage transplant, but instead of taking a donor or cadaver tissue, it almost looks like a contact lens with metal on the back, and we implant that into knees. And my patients who've had that have been very happy because it doesn't cause the same amount of swelling. They're allowed to put weight on it much more quickly, but that's an FDA trial. So far, it's about 31 patients. So, you know, we don't know yet, but so far, so good. So, and then there's a umbilical stem cell study that we're hopefully going to start next January. That's a Korean company where they've done a bunch of these surgeries already in Korea. The results look very good, and now the FDA is letting us start doing it here. So there's constantly new things coming, and you know, you don't know how good they are until you try them.
Absolutely. And it's very exciting. Your mission has been, and I think it's always been, right, to get people back to their active lifestyles. And that's so inspiring. And thank you for that. But for anybody listening who might be nervous about seeing a specialist, especially if they're active or athletic, what would you say to encourage them to take that first step if they're having issues?
Well, even though I'm a surgeon, 50% of my patients never have surgery. So you don't know until we actually take a good look and get an MRI. And there are a lot of things that we can do without surgery. But again, I'm a surgeon. I like to do surgery. But if let's say I see you and I say, you know what, there isn't a surgery for you, I'll either send you on to a non-surgical doctor, or if maybe you just need gel or PRP, I have two amazing physician assistants who do those injections all day long. So there's lots of patients who don't need me, but they don't know they don't need me till they see me. You know, so I think that it's a little scary sometimes. You don't want to see a surgeon because you're like, well, absolutely, I don't want surgery, but you don't want to let things get to the point where it's so bad that the next surgery is a knee replacement.
Absolutely. And finally, where can listeners find out more about you, your work, and make an appointment at a hospital for special surgery to see you?
So you can go through the HSS website, which is just hss.edu, and type in my name, or you can just go to sabrinastrickland.com. So that's the easiest. And I try to post, I'm not super great at social media for my family, but I'm really good at it for my job, because I constantly am reading articles and I'm posting things that I think are interesting for my patients. I was just at an international conference, and surgeons from all over come up to me and say, I really appreciate reading what you're doing. And I really think of that as posting it for my patients, but I also post it for other doctors because, you know, I don't know everything. I know nothing actually that's going on in ophthalmology or in throat surgery or cancer, but I know about my field, and so I like to share that knowledge. So
that's
just
awesome.
Looking at my website,
So you're also on Instagram and Facebook.
Right. I think far more people probably look at Instagram than Facebook. Yeah, both of them.
All right. Well, I thank you so much for being on the show today and taking the time out. This was so informative. Thank you so much.
My pleasure.
Thank you all for listening to the show. If you're facing knee or shoulder issues, don't wait. Be proactive about your health and seek expert care to get back to doing what you love. Learn more about Dr. Sabrina Strickland at sabrinastrickland.com or go through the Hospital for Special Surgery website. Until next time, stay active, stay informed, and take care. This show was produced by Hillary Topper and sponsored by the Russo Law Group, Long Island's signature elder law, estate planning, and special needs law firm. For more information, visit vjrussolaw.com. And PlayTry, your multi-sport specialist for all your triathlon needs. They have so many opportunities, including franchising. If you love the sport of triathlon, check out playtry.com and learn more about opportunities, or if you want to shop there, check them out. They've got great prices and they've got amazing customer service. Yes.